Dr. K. Gupta, sir. And Dr. Rajadhar, sir. नहीं ठीक है चेयरपर्सन सर चेयरपर्सन बस बैठना है सर दो इधर बैठे साक्षी तुम्हारा now this is the case study by Dr. S. Sakshi Pathak. साक्षी तुम्हारा ये है ना
actually
साक्षी तुम्हारा तो कुछ है नहीं
good evening
बोल देना स्लाइड दिखाओ
exactly we are running about 40 minutes late 40 to 45 minutes late so only option is to cut short little session or else you go for and as you have heard next is a panel discussion on cardiorespiratory breathlessness and case presentation. Oh, something else. So before we have a case presentation, yes, go ahead.
Good evening, everyone. So let's begin the session with a case presentation on acute onset dyspnea. I am presenting the case of a 56-year-old hypertensive and diabetic female, resident of Babatpur, Varanasi, presented to Breath Easy Emergency Room on 2nd of June 2023 with a chief complaint of shortness of breath from past 5 days and cough from past 5 days. As stated by the patient's husband, she was apparently asymptomatic 5 days back when she developed shortness of breath, which was initially present on doing strenuous work, but later on progressed to such an extent that her daily activities were affected. The shortness of breath worsened in spine position and relieves in sitting position. The shortness of breath was also associated with chest pain, palpitation, and excessive sweating. She also has a history of dry cough from past 5 days, which comes in bouts. Her husband also complains that she has been snoring loudly during the nights. In the negative history, there is no history of fever, no history of heartburn, regurgitation of food, no history of any recent new medication started, no history of acute blood loss, no history of recent trauma to the chest, no history of prolonged immobilization or recent surgery, no history of mood fluctuations or any such episodes in the past. There is no significant personal or family history present. In the general physical examination, the patient was lying comfortably on the bed, was in altered mental status and was lying in the bed with labored breathing and following vitals. Her SpO2 was 80%, her pulse rate was 110 beats per minute, regular and palpable. Her respiratory rate was 38 per minute with the use of accessory muscles and tracheal tut present. Her blood pressure was 84 by 60 mm of Hg. Her temperature was 97.6 degree Fahrenheit. There is no pallor, icterus, clubbing, cyanosis present. Bilateral lymphadenopathy is, bilateral pedal edema is present. On auscultation of the chest, bilateral diffuse wheezing sound was heard and coarse creps were heard. In the heart sounds, S1, S2 was heard with no obvious murmurs heard. The initial X-ray is given below, suggestive of bilateral opacification of lung fields. The initial ECG done showed sinus tachycardia with no ischemic changes. The 2D echo couldn't be performed due to non-availability of portable echo machine. In the lab works, her hemoglobin is 11.9 gram per dl, slightly low. Her TLC is 20,000 per mm cube raised. Her CRP is 20 milligram per dl, also raised. OTPT were also raised. Serum albumin and total protein was below the normal limit. PT, INR and APTT was within normal limit. D-dimer was 1000 nanogram per ml raised. Serum creatinine and urea were within normal limit. Her RBS was 220 milligram per dl and HbA1c was 6.8 gram per dl. Her ABG was suggestive of respiratory alkalosis with a pH of 7.4, PaCO2 of 32 and bicarbonate of 26 milligrams. The troponin, initial troponin levels were less than 0.6 and the initial CKMB was 1.9 nanogram per dl and the NT-proBNP was 350 picogram per ml. 2 hours later, her NT-proBNP was 228 picogram per ml, trop-I was 1.8 nanogram per ml and CKMB was 2.3 nanogram per ml. So that was my case presentation. Now I would like to call Dr. S.K. Pathak sir to continue the further discussion.
Thank you, Dr. Sakshi. You have presented a nice case. This question open for the panel discussion, for all panelists to discuss the diagnosis and what the probability, what the management. Just comments from the Dr. Rajadhar, the case.
So thank you, Sakshi. Well presented. Very nice. Very confident. Well done. So you got a 56-year-old lady who's got features on symptoms which look like heart disease. So someone who has intermittent chest pain, uncomfortable on lying flat, breathless on lying flat. When the patient sits up, the patient feels less breathless. This goes on for a few days. The breathlessness gets worse. The patient has high oxygen requirement. So like we were discussing before, your question here is this cardiac? Is this respiratory? You also saw that this patient is hypotensive with a blood pressure of 84/60. You also saw that this patient had bilateral pedal swelling, ankle swelling, which was significant. The chest auscultation showed both wheeze and crackles at both bases. So my first differential here would be heart failure secondary to a cardiac cause. So you also saw that troponin went up from 0.6 to 1.8, but the normal cutoff for troponin was 1, I think. So, so that's my first. So pulmonary edema, cardiac is my first diagnosis. The patient also has a raised white cell count, etc. So you would think about this being a consolidation and pneumonia, which is heard as crackles on both sides of the chest. And maybe the patient is septic, because of which you have hypotension. So that would be my second differential diagnosis. And I think I would stop there. I can see on the screen that there's pulmonary embolism. I don't think you would hear so many cardiac signs in someone who's got pulmonary embolism. Even if there's pulmonary embolism, it would be secondary to one of the other things that you've had, either the heart failure or the pneumonia that we spoke about. So that's my sort of broad outline of what I think.
Thank you, sir. Dr. K.K. Gupta, sir, any medical points from your side? Yes, sir.
So there is a cardiac failure. On the top of it, you see, please go next slide. You leave apart, next slide please. Next slide please. There are the two things. The pedal edema is present, and the auscultation you don't find the heart sounds. S3, S4 is there.
Yes, sir. Yes.
It is there, you are not mentioned here. S1, S2 is there.
So this is the superficial case presentation for this final discussion. Thank you, sir. From the Dr. A.K. Pandey, sir, as a cardiac points of view.
The case was very interesting as usual, as we are discussing regarding the cardiopulmonary points. I have got two issues to be raised. That as the patient is having all those coronary risk factors, she is postmenopausal, she is diabetic, she is hypertensive, she has an acute onset symptoms, and all these differential diagnosis has to be tested in this case. I have got a doubt that patient will have a normal ECG. Why? Because if the patient is hypotensive and raised troponins and raised BNP, patient will not have a normal ECG. Sometimes it happens that patients with left main disease, they have got a diffuse ST segment depression that is missed many a times. And the most important investigation in this group of patients in an emergency department, in spite of this point of care biomarkers, is a bedside echocardiogram, which an MBBS registrar or any physician or any graduate or emergency medicine person can put on the probe in his over the chest of the person and can see what is the left ventricular ejection fraction. Nowadays, all emergency medicine and critical care physicians, they are having point of care ultrasound, and they can see that whether the patient is having a, raised pulmonary artery pressure, or the LV function is there, or the patient is having a tamponade, or whatever the cause is. And even you can do the lung ultrasound as well. So what I will need to investigate in this patient, I should have a bedside, at least an ultrasound machine to see for the LV ejection fraction, to see for if the person is trained enough to see for lung ultrasound, even we can see what is the status of pulmonary edema in this patient. So I strongly agree with all my fellow colleagues that those who are discussing the point of cardiogenic pulmonary edema, that's a possible diagnosis in this patient compared to the respiratory cause itself.
So,
Yeah, sometimes
The-
it is pretty high compared to what we see in acute coronary or acute MI patient. Might be that patient is diabetic, she had some acute viral infection or acute chest infection which has precipitated the acute coronary syndrome, and patient had landed up in a hypotension and acute coronary syndrome. Sometimes we get, lot of intermixing, as sir has rightly said, that patient nowadays, those who are underlying coronary artery disease or underlying, LV dysfunction has developed some of the other respiratory viral infections, and they precipitate as an acute, heart failure as well.
What is the need of doing CPKMB in this when you are doing troponin I? Is it required?
These biomarkers are done in a series. Like if you do CPKMB only one point of time, it may be normal, as she has already said. Doing a set of CPKMB, in 24 hours, 3 sets at 8-hour interval can give you the, rate of rise. Sometimes it rises, after 8 hours. Troponin I also has got a similar type of, these two are the biomarkers for the cardiac origin. Sometimes, CPK may be normal in the early phases. Troponin may be rising, faster. So if you do at least two, because doing a single troponin test or a single CPKMB doesn't make any sense. Like patient comes to us in an emergency with a chest pain and we do a troponin, somebody has done a troponin and it says that troponin is negative, patient was sent home. That's a wrong practice. We should at least do another troponin or a CKMB at least 12 hours apart, and if both the values are in the same range, it's not rising, then only we can say that patient is not having any acute coronary event.
Sir, BNP value is very important for this patient. How the aspect from the diagnosis and correlated diagnosis? Yeah, Dr. Pandey, sir.
Can you repeat the question?
BNP value is higher here.
Yeah.
It's normal. Normal is 80, but here it is 282.
Patient has developed acute coronary event, then due to acute coronary event, patient might have an LV dysfunction or acute pulmonary edema. That's the reason why the BNP level is high and troponin level is also high. There is an acute ischemic insult because of underlying coronary artery disease, which might be there for a pretty long time, and this chest infection or the acute coronary event when got precipitated, patient has developed heart failure and acute pulmonary edema. That is why the BNP levels are also raised.
I have a question.
Yes.
Do you think the BNP is slightly on the lower side as compared to what you would expect in someone who's coming with fulminant heart failure?
Definitely, because the level of BNP levels are related to the LV function or LV dysfunction. As this patient has developed hypotension and she is so grossly in acute pulmonary edema, I expect a BNP of 1000 at least for her. Because it is said that if the BNP level is between 400 to 1000, in these patients, if they are not having renal failure, because renal failure patient may also have a high BNP values. If they are not having a renal failure, then we should need to do a early echocardiogram to see what is the status for the LV function.
Sir, there is a question from the Dr. K.K. Gupta, sir. There is no any history of the fever here. Our TLC was too high. And X-ray was the, why not it be the pneumonia?
Already answered that. That was a neutrophil count and lymphocyte count. what was the neutrophil count? Because if there is any stress, leukocytosis does happen.
Yes, sir.
And there has been a stress in this case because patient is already having two comorbid conditions. One is hypertension and another is diabetes mellitus. So we cannot ignore any kind of infection whatsoever. Probably it can be the viral pneumonia which might have precipitated the coronary syndrome also. So in this case. So what we are thinking in this case, probably this could have happened. Further, यहाँ आने से पहले हॉस्पिटल में स्टेरॉयड दिया गया था या नहीं दिया गया था मुझे नहीं मालूम. तीसरा, जब हम कभी आईसीयू केयर में हमारे पास टीएलसी अप हो रही हो और प्लेटलेट डाउन हो रही हो, तो ये एरर होती है हमारी एस्टिमेशन की. जो हम लोग अपने यहाँ ऑटोमेशन से करते हैं तो उसमें स्मॉल साइज़ की प्लेटलेट मिल करके जोड़ करके ल्यूकोसाइट बन जाती हैं. ल्यूकोसाइट का साइज़, क्योंकि वो आइडेंटिफाई नहीं करता, वो तो साइज़ आइडेंटिफाई करता है. जो 5 पार्ट आपका सेल काउंटर होता है. तो अगर मान लीजिए 2-3 प्लेटलेट्स मिल करके उन्होंने ल्यूकोसाइट का साइज़ बना लिया तो ल्यूकोसाइटोसिस अप हो जाएगी, प्लेटलेट डाउन हो जाएगी. दैट इज़ व्हाट यू कॉल a pseudo-leukocytosis and pseudo-thrombocytopenia in ICU care. That happens very many a times. But in this case, I will suspect that probably the patient is diabetic, might have had some kind of an infection which has caused the leukocytosis. Per se, it is not an stress leukocytosis.
And
Sir,
sir, we cannot rule out the UTI also, though it is not mentioned specifically here. Being a female patient and diabetes, UTI also is a
This is- yes.
yes, to be kept in mind.
Is there any comments from the Dr. B. Tomar as why it not be the ARDS or something pneumonia with ARDS with history this radiological picture it's look like the ARDS.
Look like ARDS, but the overall clinical picture starting from orthopnea, low BP, and all these things more in favor of cardiogenic hypotension, this cardiac pulmonary edema. And ARDS is basically from any no history of any insult. No patient is not having any history of fever, throat pain, no aspiration, no any inhalation history. So very unlikely it's ARDS. So, and regarding the leukocytes, we found many times such type of raised leukocytes counts totally. It's purely cardiogenic, I think, because no history of any infection. Patient not having dysuria, patient not having any throat pain. So any history of viral infection, patient is not having. Simply orthopnea, dyspnea, and white lungs. If you are not having echo even, you give the diuretics and other things, patient will, if resolution occurs within 12 hours or 6 hours, you can make a diagnosis without even echo. But echo is first thing we have to do. In emergency, first thing put the probe. Yeah, it's very important. Another thing you can ask the raise D diameter. Very important thing is thousands. Again, that can be lead to the one probability. Patients are having all these features, raised 1000 D diameter can lead to remote possibility for discussion pulmonary embolism because she is having hypotension also. Hypotension, this type of pictures, chest pain can lead to sometimes, we can't rule out pulmonary embolism at this moment also, but more in favor of cardiac, this acute coronary syndrome.
Sir, Dr. Pandey, sir, there is a raised D dimer in this case. What the cause is? It is simple due to the
D-dimers may be falsely raised sometimes, and as Dr. Tomar sir has already pointed out this topic that, if we have got a bedside echocardiogram, we can even rule out acute pulmonary embolism as well. Because acute pulmonary embolism leading to a hypotension means patient has developed an acute cor pulmonale. Acute cor pulmonale patient will definitely have a severe TR, severe PA pressure, RV dysfunction. So with only one investigative tool having a bedside echocardiogram will rule out all the investigative, will give you all the answers to this query that the patient belongs to, that's an acute pulmonary edema because of cardiac origin or it's a pulmonary embolism. Because sinus tachycardia may be there with pulmonary embolism also. I always have a concern for normal ECG in this patient because any person who is having such a type of presentation will definitely have some sort of ECG abnormality in the form of ST depression or widening of QRS. Sometimes we see that widening of QRS with tachycardia, those all can be there.
Sir, there is a raised of the troponin. Initially it was normal, but after 10 hours it's raised.
Yeah, that's what I said, that, you know, there may, because what I have mentioned about that, you know, the biomarkers over at least 12 hours of period, you should always repeat it. First values may be normal. If the patient comes to you within 1 hour, 2 hours, 3 hours, maybe troponin values may be normal or maybe just borderline. But if you repeat it after 12 hours, within 24 hours, at least if the second value goes up from the previous value, that suggests that patient has probably some myocardial insult and the values are rising up. There is no value of a single unit of troponin or CKMB for the diagnosis of acute coronary syndrome. You need to do a serial, at least if you cannot do 3, at least do 2 at an interval of 12 hours apart.
Sir,
That's true. That's true.
sir, Dr. Rajendra Prasad, sir.
Dilatation should have been there if it is a cardiologist, cardiopulmonologist. इसमें है X-ray में
So there is a diffuse, you know, it is difficult to comment upon the cardiac size because there is a soft fluffy shadows and yeah.
So Dr. Rajendra Prasad, sir, this is the X-ray. So if patients came with history, without history, the X-ray is finding the opacity. What the probability from your side?
What has been discussed, this is probably a cardiogenic thing, and that has caused these shadows. And as far the size of the heart is concerned, it is very difficult to comment, but there doesn't appear to be a enlargement of the heart size in this X-ray. Yes. It was APBU or PABU? Patient was lying down X-ray or?
Sir, it's a lying down position. Lying down position, PABU. The emergency departments.
Yes. So she has some, I mean, if it is lying down X-ray, very difficult to comment.
Just initial stage as ECG was.
3, 4, 5, 6.
Yes. Yes, sir.
It means she has some background picture of some COAD like picture.
Yes.
Bronchoscopist pulmonary
Yes, sir.
disease like that. Because patient is lying down and so heart is so, the lungs are so big, so there appears to be overlap. Yes, something overlap.
Sir, Dr. Rajendra, sir, there is a raised of CRP. What the cause of the?
So I think we have said that this is probably underlying infection which has triggered the coronary event in this case. So I think it goes with that. We have a raised total count, we have a raised CRP. And I think we often see these patients who either have a lung infection or a UTI, as was said a little while ago, which triggers a coronary event because of ongoing bacteremia. So I think it's just a reflection of that.
Overall comments from the Dr. Rajendra Prasad sir about this case. We have to discuss the conclusion.
First, I would like to congratulate Sakshi for in such a young age, and I believe she is an intern. So, intern presenting such an interesting case, I must congratulate her. And overall, I thank all the panelists who has discussed case very well, and most of the points have been answered. In a clinical case scenario, it is difficult to say that you can answer 100% questions. So, but I believe in this case, most of the answers, most of the questions have been cleared, and I just say thank you to all of you. We are running very late.
Yes, sir. The correct diagnosis we have made that the acute cardiogenic pulmonary edema for this case, and patient is responded with diuretics and the infection. Patient treated well. After 3 and 4 days, he was left of the hospital with complete treatment. So I thank you so much for this kind case discussion. If any comments from the Dr. Rajadhar sir in closing comments?
No, I think everything has been said. I think any patient who comes in breathless, this is the most important question to answer for the youngsters. You know, you need to find out whether this is cardiac or whether this is pulmonary. There are certain rare causes like pneumothorax, pulmonary embolism that you need to think of. And I always tell my juniors, when a patient comes into ICU, very breathless, high oxygen requirement, go through this checklist in your own head. So you start off with thinking about heart failure, which even in my ICU is actually more common as compared to pneumonia. Then I run a respiratory intensive care unit. And then you would have a pneumonia along with ARDS, sepsis, etc. And then I would think of a pulmonary embolism. Then I would think of a pneumothorax. And then there's a exacerbation of underlying chronic respiratory disease. So an exacerbation of COPD, an acute severe asthma, an ILD exacerbation, etc. So compartmentalize these causes in your own head and try and tick each of these in trying to come to the correct diagnosis. And often you will have an overlap of causes. It's not going to come to you as a pure heart failure or a pure pneumonia. Often you will see a patient who's got bad COPD, comes in with an exacerbation but is very breathless because they have a pneumothorax, which you have not managed to pick up because there's reduced air entry in the lung. So that's the way to think about, I think, a differential, and I think, like Dr. Rajendra Prasad said, very nicely presented case.
Thank you, Dr. Dhar. I think it's perfect case for the saying that most of the diagnosis, 70% diagnosis you can make by the clinical history, 15% by examination, and 15% by the investigation. So the ideal case, perfect case for the clinical and physical examination. You can make a diagnosis and you can treat these patients. Thank you, sir.
Just any, yes, closing comments. Closing comments, sir, from Dr. Deepak Talwar.
As Dr. Rajadhar and everybody has observed, it's a very clear-cut case of a cardiac origin, and as the history suggested of orthopnea, that itself takes you away from the respiratory side.
Yes.
And of course, other things will just confirm the cardiac origin. That's all. Thank you.
Thank you, sir. Dr. A.K. Pandey, sir, closing comments for this case.
I think we have discussed most of the things. I just want to add that we can do one other marker, that procalcitonin, to see that if there is any evidence of sepsis or infection. That's all.
Thank you so much for kind discussion.
One question from
Yes, sir. Any question?
What is your final diagnosis?
The diagnosis was as acute cardiogenic pulmonary edema.
Acute cardiogenic pulmonary. Why infection
No,
counts. Patient having the sepsis, multi-organ
No.
syndrome.
There is no history
that
of it.
developed to the congestive heart failure without 2D echo. How you confirm? Your ECG is normal. Sinus tachycardia is present. No ST changes and other changes. How you confirm the diagnosis from this patient?
The patient initially started with treatment and diuretics. The patient is fine.
That's what Dr. Singh has raised, that the question was framed to, create a confusion among the audience and the panelists. And that's why when a cardiologist is sitting, the ECG was not posted here.
Patient having the sepsis and multi-organ failure, maybe patient having the developed
We do agree with you, but as Dr. Rajan sir has said that we are running short of time. This question is for discussion, and so for hypothetical question is for discussion. But
Yes,
it is impossible to have a hypotension without an abnormal ECG. There is a dictum written in any of the textbook. You cannot have a hypotension in acute coronary syndrome with a normal ECG, and this ECG is not normal. Patient is having sinus tachycardia.
Yes.
Sinus tachycardia is not a normal rhythm.
Sufficient to prove.
Thank you, sir. We are getting late. Just we have to facilitate.
Thank you, sir. Now I would like to call, first of all, Dr. Sakshi to come here. Yeah. And would like to call Dr. K.K. Gupta, sir, to present bouquet Angvastram to Dr. Sakshi for presenting the case. Would like to honor chairpersons also, so would like to call Dr. S.K. Pathak sir to present Angavastram to Dr. Rajendra Prasad sir, Dr. K.K. Gupta sir, and Dr. Deepak Kalra sir. Now I would like to call Dr. J.K. Mishra sir also. बस सर आए सर 1 मिनट लगे सर would like to call Dr. J.K. Mishra sir to present Angavastram to Dr. Rajadhar sir, Dr. Veerottam Tomar sir, and Dr. A.K. Pandey sir. Thank you, faculties. Please have a chair. Dr. Thomas, sir. Thank you, sir. Please have a seat.